I really do mean that pathology does sit at the intersection of diagnostics and precision medicine because it provides like a foundational understanding of the disease biology that informs every aspect of the patient's personalized treatment journey. And I think that this intersection that I talk about is crucial, especially when it comes to the personalized precision treatment decisions that are made for patients. So I feel like pathologists are no longer just determining what the tumor is, whether it's benign or malignant, what the actual specific etiology is of the disease, but they're also now identifying specific mutations, also molecular signatures and biomarkers to guide treatments.
Welcome to the People of Pathology podcast. I'm Dennis Strank. On this podcast, we explore pathology, one story at a time, and connect with the people behind the diagnosis. Today, we're exploring how innovation in digital pathology and molecular diagnostics is reshaping the future of cancer care. Dr. Osama Khan is a pathologist at Natera. We'll discuss his work with circulating tumor DNA and molecular residual disease testing. And we'll talk about how this technology is helping to redefine early cancer detection and monitoring. All right, let's get into this fascinating conversation with Dr. Osama Khan. This is where I start with most people, your path into pathology. So I'm curious, is there like a key moment or a key experience or a person during medical school that led you into pathology?
Right. That's a great question, Dennis. And, this is a great question that I get asked from a lot of people, just saying, oh, how did you get into pathology? I didn't even know it was a specialty. So
Yeah.
I think that was how I was as a medical student. You get during your training, you either make a decision. Are you doing medicine or are you doing surgery? And that was kind of how I was too. However, when I was in medical school, one of my favorite courses was anatomy and physiology. And I really enjoyed I was able to dissect cadavers, learn about the human anatomy, and it really gave me insight into the gross organ anatomy, which really piqued my interest with regards to the pathologic disease process. And then when I got into my senior level classes in pathology, it made me even more curious and reinforced my desire for exploring the specialty. And I remember when I was on one of my hospital rotations, I was doing as a third year medical student, I was doing a rotation, I believe, in MSK or orthopedics. And we had a case and I was doing this research project with this orthopedic surgeon. And he actually said, you know what, we actually want to look at the pathology of this disease. Why don't you go down and sit with the pathologist? And, that was my first insight into the pathology specialty. And it was really great learning from that pathologist about bone anatomy and just histology in general. And I think that was my early intro into pathology, and it just kind of went from there.
Okay, I see. Yeah, I have noticed. I don't know if I told you, so I'm a pathologist assistant, and I have noticed that the orthopedic surgeons are the ones that are it seems like are the most interested in the gross specimen. So that the
Yeah, I
story
mean,
you just told makes sense.
for sure. Yeah, definitely. And I think from there too, I think one of the things that you get during your training is you always get mentors. And I think for me, a lot of my mentors that I was working under, they were GU pathologists. And
Yeah.
I think that kind of also made me pick the subspecialty as a GU pathologist and then complete that fellowship. So I think during my residency, I also got mentors along the way. And that really reinforced kind of the subspecialty that I would pick as well. So I think it's really important that exposure is so paramount when it comes to reinforcing like your education around a specialty you're going to pick, but also even into fellowships you're going to go into. And I think that was a big reason why I kind of chose the fellowship that I chose.
Sure. In almost all of the conversations I've had on this podcast, people mention mentors and how important they are in kind of steering your career path. So it's interesting that you agree with that as well. I've read some things you've written, some other podcasts you've been on, and something you mentioned that I wanted to ask you about. You mentioned that pathology sits at the intersection of diagnostics and precision medicine. Can you elaborate on that? Like, what do you mean by that, and why is it important?
Yeah, that's a really great question, Dennis. And I really do, when I say that, I really do mean that pathology does sit at the intersection of diagnostics and precision medicine because it provides like a foundational understanding of the disease biology that informs every aspect of the patient's personalized treatment journey. And I think that this intersection that I talk about is crucial, especially when it comes to the personalized precision treatment decisions that are made for patients. So I feel like pathologists are no longer just determining what the tumor is, whether it's benign or malignant, what the actual specific etiology is of the disease, but they're also now identifying specific mutations, also molecular signatures and biomarkers to guide treatments. And I think that pathologists are absolutely crucial because we are the ones that are, when a biomarker is ordered, for example, like a PD-L1 expression for certain tumors. Say, so if you have a lung tumor, you have an oncologist who's going to order a PD-L1 biomarker. Specific determination of its expression or anything related to that is definitely read by a pathologist, and we are the ones that issue that report. And based on whether or not that's positive or negative, that can really influence the immunotherapy, for example, or targeted drug eligibility based on what we say. And I think that is, we are already in the future. This is like something that's not going to go away. And I really do feel that pathologists have a significant impact and something that really excites me about the present and future of kind of the practice of pathology.
Yeah, it's interesting. This kind of era of precision medicine has shown that pathology has become more of the driver because you're not just making the diagnosis anymore. You're actually directing treatment in some ways too, right?
Yeah, absolutely, Dennis. And one thing I would say is, one thing that I really appreciate about the specialty of pathology, it's a very collaborative specialty. And I think that this multidisciplinary discussion about treatment options is paramount for patients. And something that I actually tell if I do have a patient who wants to discuss a pathology report or has questions, one thing I do stress to them, and it is, your case was discussed with a multidisciplinary team of doctors. And I think that really gives them comfort to say, hey, my case was challenging and it was difficult, but we had multiple specialties that garnered their opinions to essentially make the most diagnostic, accurate treatment decision. And I think one thing that I learned during kind of my training was pathologists should be sitting at the head of those multidisciplinary discussions and really not sit in the background because they're the ones that not only are they making the bottom line diagnostic kind of report that the patient is all of their treatment is going to be based on, but we're also signing out the biomarkers that were ordered.
Right.
And I think that we really need to discuss it and sit at the kind of the head of those tables and not be afraid to speak up because we're only benefiting the patient.
It was an episode a long time ago, and somebody had mentioned very much that same thing. I forget which one it was, but he said that in those multidisciplinary tumor boards, I know it's called different things in different places, but in that room, the pathologist is the only person that has all of the information, right? And it's all the things you just said. They've got the pathology results. Yeah, they can see the radiology results. They've got the tumor markers, all of that stuff. But I wonder, because you mentioned the pathologist really should be more leading the discussion. It seems like that's a kind of a different role for a lot of pathologists. Do you know what I mean by that?
Yeah. And what I say is like, leading the discussions, I think that a lot of these tumor boards, they operate differently. But for example, I would say from the GU perspective, when I meet with my fellow urologists, surgeons, radiologists, that's one of the things that I really appreciated during my fellowship training is how open and collaborative that subspecialty was. And that's the thing with these multidisciplinary tumor boards. They all have function the same, but they are broken down by subspecialty. And so they may operate. And I think that's one of the things that I also really appreciated about my fellowship training is I really enjoyed the team that I worked with, the greater team outside of pathology. And I think one thing I love, and I'm sure we'll talk about it too, is my kind of interest in digital pathology and it definitely plays a great role in these multidisciplinary tumor boards is because we are image based and
Yep.
showing these images in a like high quality images, just like radiology. They're doing that all the time. They're showing these images. They can pull it up on the screen. And historically, what did we have? We had we have glass slides. And sometimes, and I think this was a big disservice to patients. Sometimes we're not able to show the actual pathology because we're on glass slides. We may have a scanner available to us in the department. We may not. We may
Okay.
have a camera mounted to our microscope where we can show potentially live real images. But I think that, that's not standard across the board. And I think we lose a big part of that discussion during those tumor boards if we're not able to show the images. And I think that the advent of digital pathology, which I definitely use in my practice, is something that really can enrich the discussion. And when you can show those images, almost like light bulbs go off for the clinicians and, and if patients are shown those images as well, I
Yeah.
think that that has really helped to kind of color that discussion about patient care, being able to show those images in a timely fashion.
Sure. I definitely agree. You said you have the interest in digital pathology. When did that start? Or how did that start, I guess?
Yeah, so I've always been interested in cutting edge technologies and
Okay.
I think that I know that digital pathology was up and coming. And one of the amazing things was I was able to see both worlds. During my residency, it was a 5-year anatomical pathology residency. We had a scanner, but it was one of the kind of those old school imperial scanners. There was a large kind of error rate with those scanners. And so we didn't have digital pathology, like an actual like image management system. But what we had was a scanner where we could scan glass slides. And if we can download them onto our computer screen, we'd have to probably plug it into a PowerPoint slide and kind of show it. So it wasn't like a real time image, it was kind of a static image. So I would say that during my whole training, I didn't get any exposure to digital pathology.
Okay.
However, I always piqued my interest when I went to conferences, any kind of the large, like local and national conferences, there'd always be vendors for digital pathology. And I
Yep.
really started speaking to them. And I really was able to vet a lot of these vendors because I was like, you know what, this is going to be the future. I really want to implement this into my practice. And then when I switched over to my fellowship at Stanford for GU, they were fully digitized. So
Ah,
I really was able to use the digital pathology for its intended use in an actual diagnostic workflow. And that was a really enriching experience because of everything we just discussed. I was able to look at these images remotely. I was able to order stains before I even got into the office the following day. But then also I was able to participate in those multidisciplinary rounds with my urology colleague and show them those images, which they really appreciated. So I was able to kind of see it during my training. And I think that one of the things that's really important too is we're talking about subspecialties. I think, GU is an absolutely amazing specialty when it comes to digital pathology. A lot of people, the tissue type that they use to kind of use those validation studies are prostate biopsies. And I think that's one of the things that really piqued my interest is contrary to what some of my colleagues might say, I actually like looking at prostate biopsies and looking at them in a digitized format is just even more enriching and it's exciting and you're able to do so much with it. So I think that I'll never go back to the traditional kind of microscope unless it's really required due to maybe some IT issues or whatnot. But
right.
I think that, for me, any digital pathology will always kind of be in my practice from now on.
I like that perspective. Now, I wanted to get into because you're working with Natera now, and I wanted to get into how you got into the industry world, I guess. Like, what was the turning point that made you decide, okay, I'm going to move from academia into industry?
Yeah, that's a great question. And I think that's like one of those things where, during my training, there wasn't a lot of exposure to the different, other than just it being in an academic hospital or a private practice, there wasn't too much education around the different types of roles for a pathologist.
Right.
And I think that is across the board. That's just, and I think it's kind of multifaceted, right? There's many layers to that. Why? Because our training programs, they are 4 years, 5 years, and it's jam packed. There's just no time unless you go outside of your, you go outside of your core disciplines and kind of modules and go do an elective. And there's really no time for it. And I think for me, I was fortunate enough to be at Stanford doing my GU fellowship. And they actually do, because of geographic location being in the heart of Silicon Valley and the heart of like biotech companies, there was exposure. People would talk about it during my fellowship, that, oh, I know so-and-so, he's an industry pathologist who works at biotech, either full-time or a consultant. And so then I got really interested, like, I've always had this interest in industry just from my digital pathology exposure, looking at vendors, talking to them, that really excited me. And I kind of want to be like, I really like digital pathology. I really like this precision medicine and access to these cutting edge technologies. Why don't I explore potential avenues? And I was also thinking about doing a molecular genetic fellowship. Those are some things that's a hot topic right now, to have molecular training, as we had just discussed, with its association with precision medicine. So I did some electives in molecular pathology as well. And I thought that I'd be doing another fellowship in molecular pathology, and then, I could get more exposure. But it was like the right place at the right time. I was in the area, and there was an opportunity that came up with Natera. And they were like, hey, we're in kind of a fairly new company. We're looking to open up a new CLIA approved lab in the California area. We're looking for a pathologist to kind of head that lab, and just specifically for our oncology product. And I think that was it was a kind of a leap of faith. It was like fresh out of fellowship, but it was the right place at the right time. And, fast forward 3 years, I've been there, and I think it's probably one of the best decisions I've ever made.
Okay. What would you say was like the hardest part, or the biggest challenge of making that jump?
Yeah. And I think that, that right there is that whole, when I say leap of faith, and I think that comes from the fact that there isn't a lot of exposure, right? You don't know what you're getting yourself into. And I think that in itself can be a bit of a challenge, because it's different, right? We know how to navigate, and being a pathology assistant yourself, Dennis, I think we know how to navigate kind of a hospital system, where we fit in, we know what a pathology assistant does. We know potentially what a pathologist would do, depending on what subspecialty they choose. So that's familiar to us, because that's what our training programs are set up for. But when it comes to industry, you don't really know your role. The training that you've had, but it's beyond that too. This is this was an industry company, but it was also publicly traded, right? So there was a big push towards the business side, in addition to patient care. So that right there, that intersection was something that was challenging to navigate, because you had your core disciplines as a pathologist, scientifically sound kind of decisions, making diagnostic accurate decisions. But then there was always these questions from the outside too, with regards to the business aspect. Can we accept this tumor type, for example? And you'd have to educate them that, hey, this actually is not an invasive tumor. This is actually a precursor lesion, for example. And our test, which we'll get into, is validated for invasive tumors. So there was a lot of education back and forth, and that was challenging, because you were looking at both parts of it, the business side, but also the medical side. But you know what? I think that was probably a great opportunity to educate myself, and I learned a lot from that. And one thing that I realized, that just like academic medicine, even in industry, it's a very collaborative environment. And so you're working with different aspects of the company, not only the medical side. You have lab directors, you have genetic counselors, you'll have salespeople, marketing. So I think that really enriched the decision that I made, because I got to learn a lot every single day. And I think that's something truly enriching. And I've been able to, during that time, educate people about pathology, what a pathologist is, what we do on a day-to-day basis, and how we can help you ultimately for patient care.
You're listening to the People of Pathology podcast with our guest, Dr. Osama Khan. We'll be right back. When it comes to cancer staging, one of the most important parts is finding all of the lymph nodes. I should know, it's what I do every day. Yet this process has remained the same for over 100 years. manual, tedious, and time consuming. That's a problem because every missed lymph node can mean inaccurate cancer staging. That's about to change. Enter InVision from Cision Vision, a first of its kind device that's redefining the standard of care. Traditionally, we identify lymph nodes by sight and feel alone. InVision changes that using shortwave infrared technology to make lymph nodes stand out clearly from surrounding fat and in real time. In its first 104 patient study published in the Journal of Clinical Pathology, InVision helped increase lymph node counts in 86% of cases and even upstage 4% of patients from N0 to N1. I personally contributed to the study, and let me tell you, seeing the technology's impact firsthand was amazing. It's time to invest in grossing innovations that improve patient care. So, how is your lab approaching innovation in grossing? Book a demo at demo.cisionvision.com and start seeing lymph nodes like never before. Are you thinking about applying to a pathologist assistance program and feeling a little lost? That's why I created the Path to PathA, your PA school application blueprint. This is a step-by-step prep course that gives you everything you need for a strong application. From finding shadowing to writing a standout personal statement to prepping for interviews, this course was made to help you feel informed, confident, and ready. Visit www.thepathtopatha.com to join the mailing list. You'll be the first to hear when the course launches. Your path starts here. Now for the rest of my conversation with Dr. Osama Khan on the People of Pathology podcast. So let's get into Natera a little bit more. Can you give me an overview of what this company is and what it does?
Yeah, absolutely. So Natera, I would say, is a global leader in kind of cell-free DNA testing, and it's dedicated to many different products. We'll obviously talk about the oncology product, but they have oncology, women's health, for example, like prenatal testing, organ health, chronic kidney disease. So I think at the end of the day, the technology that Natera uses is cell-free DNA. And it'd be good to kind of color the discussion, just giving a little bit of background on what cell-free DNA is.
Yeah.
So what that is, every day when our cells are turning over, they go through a process of turnover, apoptosis, regeneration. When the cell is dying, it actually has its own DNA. And that can actually be detected in the blood through something called cell-free DNA. And so these are actually like little bits of DNA that the original cell puts out. And I think that detecting it in the blood is very real time. It's very sensitive, because these little fragments of DNA have a very short half-life. And if we are able to detect these, then we really know that's present in the blood because, the half-life of the cell-free DNA will then disappear. So being able to detect it is a really rich technology. So let's go over to tumors and how we can actually detect it from an oncologic perspective.
Okay.
Just like these normal cells, when they are turning over, put these fragments of DNA, cell-free DNA, tumors also do that. When a tumor is present in the patient's body, they also then put out this cell-free DNA, which we then call CtDNA, which is short for circulating tumor DNA.
Okay.
And so we can actually detect these fragments of tumor DNA also in the patient's blood or plasma. And that can then indicate to us whether or not a tumor is present if the levels of ctDNA are high. But also on the flip side, if the ctDNA is undetectable, that can really be a strong potential indicator that patient's tumor is not present or is being held at bay potentially with the treatment that has been given. And I think that a lot of this ctDNA, when we're detecting it, we arching term that we use is MRD testing. And that's short for molecular residual disease testing. So all of that, if we were to define what is molecular residual disease, that is a highly sensitive laboratory method used to detect this circulating tumor DNA, often at that molecular genetic level, after a patient has undergone treatment. So that's important to know too, is a lot of these patients, when they're testing it, I would actually probably say that MRD testing is not a diagnostic test, but it is a sensitive screening test to basically monitor the patient's treatment and how the tumor is responding to that treatment. And I think that this is a really powerful way, because what are our methods that we use now currently? It's a very collaborative approach. You'll have like the patient's kind of like clinical symptoms. You'll have radiologic imaging. Patient might go in for a CT scan or a PET scan, on whatever the timeline is, every 6 months, every year. And unfortunately, sometimes that can be too late for the patient. And that is the methods that we have. But with the advent of CtDNA detection, a lot of these tumors, they can actually be detected way earlier than our current methods, say imaging, and sometimes up to 2 years earlier,
Oh, wow.
depending on which tumor you're talking about. And that can really make two types of decisions. One is to potentially escalate therapy, right?
Okay.
But on the flip side, if that ctDNA is not detected, you may be able to de-escalate therapy and have the patient avoid these really toxic chemotherapy regimens or radiation regimens. And so that's a really great way. Is it's not all about, oh, let's start treatment, but maybe we might be able to avoid treatment. And that is what our big clinical trials show, is having ctDNA part of the treatment process. You are able to make a real-time, early informed decision about the patient's kind of future treatment regimen.
Okay. All right. So a couple of questions about all that, because that was really interesting. So as you're talking about, this is a patient who had a tumor and you're testing for ctDNA for possible recurrence, right? Is that what you're talking about?
Exactly. Yeah. So I
Okay.
think, for sure. So that's a great question, Dennis. And I know that, that this is a new technology, right? I
Yeah.
mean, this is like something for a lot of people. And in my discussions with pathologists and oncologists, people are at different levels of their education, whether or not they order MRD testing, whether they don't. But there is a huge amount of validated studies, a lot of clinical information out there, positive data to show that MRD testing has significant overall improvement in patients' disease-free survival and overall survival. So one of the things, as I had mentioned earlier too, is as a pathologist working at Natera and these MRD companies, one of the things we have to do is we have to look at the actual tumor,
Yeah.
and obviously I look at it kind of through like a digital pathology system. And we have to then detect where the invasive component is of the tumor and annotate that tumor to indicate where downstream the testing should be done on that actual patient's tumor, that tissue slide. And so, all these patients, they all have tumor. They all have cancer. They have a previous diagnosis
Okay.
of cancer. And what we ask for is the best block or tissue or on the slide that is the representation of their tumor, whether it's a biopsy or it's a resection. And so that's the bread and butter of kind of what a pathologist would do, is verify that the pathology report and the diagnosis is accurate, but also to select the best area for testing for that ctDNA. We already know that these patients have cancer, and then they most likely had certain treatment, depending on, is it first line, second line? We don't know, but maybe they have had first line treatment. And
Okay.
now we're monitoring the patient and then want to see how their tumor is responding to that therapy. And I think ultimately that's kind of what we're doing with MRD testing.
Okay. This is really interesting because you're talking about it's more personalized testing, first of all, and you're talking about detecting a recurrence. I think you said up to 2 years ahead of traditional methods, which is amazing and really helpful for patient care. And then you're talking about sort of determining if they need treatment or not. So you're eliminating unnecessary treatment or giving them necessary treatment earlier than they would have gotten it before. So a lot of benefits to this, it sounds like.
Exactly. Yeah. And you had just touched on something that's amazing that, that's something I was going to get into
Okay.
this is a very personalized test. And
Yeah.
we call these like tumor informed test, where what I mean by that is we actually design this test based on the actual signature of the patient's tumor. It's not just generally what's out there in the literature. And that's why we have two parts. One part is obtaining the patient's original tissue that the diagnosis was made from and designing like the primers or the actual targets from that patient's tumor. And then when the patient is also then getting their plasma drawn, their blood draws, to detect over time, whether it's 3 months or 6 months, you are then able to design that test based on the patient's original signature from that patient's tissue that was given in. So we call those tumor-informed tests. And that's why we say this type of a test is a very personalized test. We're not just randomly looking at certain signatures in the literature. We're actually looking at whether your cancer is a colorectal cancer, pancreatic cancer, is it breast cancer. Let's design targets based on the patient's actual cancer.
Okay. That's got to be even more comforting for patients than knowing that this test is essentially built for them, right?
Exactly.
So way more accurate, I think. Yeah. We hear a lot about AI these days, right? In every part of life, and it's coming into pathology as well. And I want to get your thoughts on this. You mentioned earlier that you like looking at prostate biopsies, and it seems like for most of the AI tools coming out, prostate biopsies is kind of the first use case, I guess. So what are your thoughts about AI in pathology, and where do you think it's going to go?
Yeah. So I think for me, because I had mentioned to you that the most up-to-date cutting edge technologies is something that I really appreciate, I am kind of all for AI. And what I mean by that is I think we need to look at our impression of what AI is and what it'll do for the practice of pathology. And I think that there's use cases that artificial intelligence can be very helpful. And I think in general, we talk about pathology being a very diagnostic specialty. We talk about workflows. And I think we want to optimize our workflows as best as possible to enhance accuracy, but also to help reduce turnaround times for the patient so they can get on to some timely treatment that's required. And I think that's one of the things that AI can help with, is helping to triage the workflow, and automating that workflow in a seamless fashion. So if you can have some AI algorithms, for example, if we take a look at prostate biopsies, let's say you have I say stack of cases, but I guess these would be digitized, but you have a number of cases in your queue before you even get into the office, and you're able to then put these prostate algorithms onto your cases. It's able to triage your workflow to maybe 3 buckets. One would be potentially benign, malignant, or that in between where it's like, a not sure, possibly malignant, possibly benign. And then so a pathologist can kind of come in and be like, okay, you know what? I'm going to spend time on these more challenging cases that are high priority, and then leave maybe the potentially benign cases for the afternoon, for example. And so what that allows you to do is it allows you to, there's only certain many hours in the day, and, looking at screens or a microscope can be very fatiguing as well. So that's like something we need to know. So you want to be able to put your energy and expertise where it's needed. And these algorithms are actually quite good. There's a lot of data when it comes to prostate biopsies that can show that it's pretty accurate when it comes to actually detecting down to the actual gland itself, the ones that are of concern. And I think that is one way that artificial intelligence, but at the end of the day, we are not saying that definitively that these are benign or malignant. It's just directing it's like an aid, right? So
Yes.
artificial intelligence is an adjunct to the actual pathologist. And I think that's very helpful, because there are just some cases that are very challenging, and you may need to have something identify it, like a hotspot or something that you may then make a decision, but then you can also go and show a colleague. And that can be very helpful, as well as making that collaborative. I was talking about multidisciplinary collaborative approach. AI is also part of that collaborative approach. And I think that's something that pathologists need to understand, that AI is not here to replace us, right? That's always something that I hear: AI will replace you. There's no way that AI can replace a pathologist, because I'm telling you, Dennis, as you know, being a pathology assistant, we can go in tomorrow to the hospital and we'll get a case that we've never seen before. We don't even know what it is.
Yep.
So that's one of the things, is we are still able to use our expertise, because there's just some cases, cancer's evolving, as we know. It's getting more complicated. The staging of these cancers are getting more complicated. And now look too, because of our intimate association with precision medicine and biomarker testing, we are now then able to have more precision and targeted therapy for patients. knowing that, which is great, but then also what that does is it changes the tumor biology as well. So if there is a recurrence for the patient, it may look a lot different because it has been treated kind of neoadjuvant treatment or adjuvant treatment. So that's another thing too, that,
Oh yeah.
just plugging in as like a plug and play for artificial intelligence, that can be very challenging because you might not be able to capture all those data points because of the complexity of tumor biology these days.
Yeah, I'm glad you mentioned that the aspect of seeing things you've never seen before. At any given week, we've got a specimen that we all kind of gather around and we're like, what is this? That, it's something we've never seen before, or maybe it's something we've seen, but a different, I don't know, variation of it or something like that. So there is always that kind of thing to think about. You've mentioned the collaborative aspect quite a few times. It sounds like that's pretty important to you. Where do you think that comes from?
Yeah, it's a good question. I think for me, I really appreciate interacting with people just kind of when I go. And, I think when it comes to like a specialty, it's interesting. People who have this image of what a pathologist is,
Yeah.
where it's obviously changed, but what we've all heard it before. Oh, they sit in the basement with their microscope. They don't see patients.
Yeah.
There's no windows, but I'll say actually working in Natera, I actually am not in the basement. I am actually on the fourth floor with a nice big window. So
No.
I joke, but it's interesting. People have this understanding or kind of this preconceived notion of what a pathologist and the specialty is. But I think one thing I learned was that we aren't making these decisions in a vacuum. We aren't sitting alone and making these decisions. We are actually, this care that we're doing and very important. We're kind of probably the last in line of making that diagnostic decision for the patient. But you know what? There's been a lot of people that have been involved. And that's why we have these tumor boards. And I really appreciate picking up the phone, talking to the oncologist or talking to the surgeon and being like, hey, got a real difficult case here. What are you planning to do if this diagnosis is A versus B? What if we can just diagnose it like this? Would this give you enough information for you to take the next step and treat? And I think that's really important because just hearing from the patient, listen, this patient, I think, based on their clinical symptoms, we're going to treat regardless because we have a strong clinical suspicion that they have stage 4 disease or metastatic disease. So that's really helpful because they're also like boots on the ground. They're treating the patient. And that's really important for us to know because we just have one single piece of tissue or we have a like resection for the patient. So it's really important to have that. And that's what we get from multidisciplinary rounds is getting the whole picture of the patient and then adding to that discussion as a pathologist. And I think now working in industry, it's the same thing. I'll get emails throughout the day, be like, hey, we have this oncologist that's really finding this patient really challenging and they're not sure which type of tissue they should be sending. Do you mind getting on the phone with the oncologist and the original diagnosing pathologist to be able to have a discussion and guide them basically what is potentially the best block to choose for CtDNA testing, MRD testing. So that in itself also is collaborative. And I don't think we could ever get away from that. And something that I really appreciate about medicine in general.
Mm-hmm. Okay. So I want to end with this. You mentioned earlier how in your own training, there wasn't a lot of exposure to, say, opportunities outside of the hospital, right? Opportunities in industry. For people listening who might be a pathology resident or medical student and are curious maybe about careers in industry, what advice would you have for them?
Yeah, I think that is a great question, kind of just to end our discussion, because I get that a lot. They're like, oh, hey, how did you get into industry?
Yeah.
What's life like there? Right. And I basically tell them, hey, I was you a few years ago, right? My curiosity was able to pave my way into kind of industry in the position that I am. So I would definitely say, really stick on that curiosity, really explore that curiosity and educate yourself. And there's many ways you can do that, right? You can, just I talked about going to conferences, go to different vendors, talk to them, ask them about their system, whether it's, say, for example, this digital pathology. Ask them about their platform. What are the advantages, disadvantages? And a lot of them will actually have their system that you can navigate right then and there. You can look at slides right then and there and in real time, but then also for artificial intelligence too. Ask them what their algorithms are, how it can help you. And I think that's another thing too is, educate yourself. And I think along the way, when you're doing that too, you will meet people that are on the same trajectory as you. We talked about mentors. Having a mentor that can kind of help you guide your decision. But even if you don't end up choosing it, at least you've actually made an informed decision. And I think that's really important. And lastly, I would say I get people to come and ask me, they just message me, hey, I know that you train at Stanford and you're working at kind of Natera right now. Can I get exposure? Can I come in and sit with you for half a day just to kind of see what you do? Honestly, things that we have done throughout our training and our fellowship, you should also do when you're looking to take the next step for industry or academia, is to go out there and really market yourself and expose yourself to a lot of these companies. And I think it can be done in many different ways. And at the end of the day, once you have all that, you can make an informed decision whether it can fit potentially into kind of one of your career pathways. And I think that's probably the best advice I could give.
I love it. I love it. That's great advice. Dr. Khan, this has been a very interesting conversation. I love talking about cutting edge technology like this, so I appreciate the opportunity. Dr. Osama Khan, thank you very much.
Yeah. Thanks so much, Dennis. It was a pleasure.
If you're looking for another episode of the People of Pathology podcast to check out after this one, here's a clip from my interview with Razik Yousfi as we talk about how advances in AI in pathology are helping to improve patient care.
Predictive and prognostic tests that may enable you to identify whether or not you could qualify for a specific therapy or drug. Making sense of all that data together is extremely complex for us as humans. Training AI solutions that can make sense of that and ultimately give better insights to your oncologist to help you ultimately get a better answer as a patient is something that I think is the future. So I really think there's going to be advances in each specialty, but I think there's going to be advances in whole disciplines of medicine altogether for ultimately better again patient care, but also better patient outcomes. Is it one foundation model or multiple foundation models combined in a certain way where you can actually make sense of pathology and radiology data together, pathology and radiology sequencing data together? I think that's what we're currently investigating as research institutions and industry.
You can hear more from Razik Yousfi in episode 198. All right, so big thanks to Dr. Osama Khan. His story shows how modern pathology is transforming cancer care and also how curiosity can lead a pathologist far beyond the walls of the hospital lab. There are 3 takeaways from this episode that I want to mention here. First, there was the discussion of circulating tumor DNA and molecular residual disease testing, or MRD testing. These technologies represent a major leap forward in how we can detect and monitor cancer. By identifying fragments of tumor DNA that circulate in a patient's bloodstream, pathologists can detect signs of recurrence months and sometimes even years earlier than current methods. This early insight gives oncologists the ability to adjust treatment strategies, whether that means escalating therapy for recurrence or safely de-escalating to spare a patient from unnecessary side effects. It's a powerful example of how molecular diagnostics are turning pathology into a driving force in precision medicine, while helping patients live longer and with a better quality of life. Dr. Khan also talked about how pathology, at its core, is deeply collaborative. Behind every diagnosis are conversations between pathologists, oncologists, surgeons, and radiologists, each bringing a unique perspective to a patient's case. In tumor boards and multidisciplinary meetings, pathologists don't just interpret slides, they help shape treatment plans. That spirit of teamwork underscores what makes this field so vital. It's the bridge between science and patient care. Finally, there's Dr. Khan's own career path, which shows that pathology doesn't have to be confined to a microscope or a hospital setting. His move into industry at Natera allowed him to expand the scope of what pathology can do, applying his expertise to molecular testing, digital workflows, and the development of tools that directly impact patient outcomes. It's a reminder that learning can take place anywhere, and that exploring new environments can open doors to unexpected, meaningful work. Dr. Khan's journey encourages all of us to stay curious, be collaborative, and be open to where innovation might lead us next. As always, I'll have links in the show notes to everything that we talked about today. Don't forget, you can follow the show at People of Path on both Twitter and Instagram, or just connect with me on LinkedIn. Thank you for continuing to share the show with others. Together, let's inspire the next generation of pathologists and laboratory professionals. This show is a member of Health Podcast Network. Thanks for listening. I'm Dennis Strank, and I'll talk to you next time on the People of Pathology podcast.